Hi, good morning. My name is Noha and I will be presenting my topic. First, I want to introduce my audience today. Let me rotate the computer.
Hi, good morning. My name is Mohammed. I'm a pharmacist at CVS Pharmacy. I was graduate in 2001.
Hi, my name is Samah. I'm a pharmacist in Aldami Pharmacy in San Diego. I graduated in 2002.
Thank you so much. And let me share my screen here. All right. So let me start. This is the topic of my presentation for the instructional method topic under the supervision of Dr. Gleason. The topic of my presentation is about the safety and efficacy of sodium glucose cotransporter inhibitors in patients with type 2 diabetes and cardiovascular comorbidities. Now, before I start on my presentation, I would like to start talking about my case, JB. So JB is a 59-year-old patient who has type 2 diabetes. She has other comorbidities, such as hypertension, dyslipidemia, history of myocardial infarction. She also has, her recent estimated hemoglobin is 8.9%. She is obese and cannot control to lose weight. Her current medications are the metformin, 500 milligram by mouth twice daily with swallow. She also has glipizide, 10 milligram by mouth twice daily. She's receiving atorvastatin once a day, 10 milligram. And she's also receiving amlodipine, 10 milligram by mouth once daily, in addition to aspirin that she's taking once a day. We would like to come out with a better plan for her treatment. What would be a good next step for her treatment plan? And also, we want to know, would she be a good candidate for the SGLT2 inhibitors? Now, let's switch gears and go back to the presentation. By the end of this presentation, you as pharmacists in the retail setting in California should be able to recall the pathophysiology of type 2 diabetes and the goals of therapy according to the guidelines. Also, review the mechanism of action of the sodium glucose cotransporter inhibitors. You should be able also to list different products of the SGLT2 inhibitor. Identify the safety of the SGLT2 inhibitors and the use in type 2 diabetes patients with the atherosclerotic cardiovascular disease, or ASCVD. You should also be able to extrapolate the efficacy of the SGLT2 inhibitors in these patients, the type 2 diabetes patients with the atherosclerotic cardiovascular disease. You should be able to identify patients at your pharmacy who will be benefiting from the addition of the SGLT2 inhibitors according to the guidelines in the clinical trials. Well, in type 2 diabetes, let's start by talking about the pathophysiology. So what happens here? The pancreas produces insufficient amounts of insulin. So this results in higher blood glucose levels. And at the same time, glucose at the muscles, they are not taken up by the cells. So the muscles is not able to take glucose into the cells. This results in increased blood glucose concentration. So we have insulin resistance that prevents muscles from making use of the glucose, in addition to the progressive loss of the beta cell function. And this increases the blood glucose level. So now, what are the risk factors for diabetes? Unhealthy diet, no physical activity, obesity, and some genetic predisposition. So patients with type 2 diabetes also face complications such as cardiomyopathy, peripheral neuropathy, diabetic nephropathy, stroke, retinopathy, and diabetic foot infection. So in the next coming slides, I will be talking about the prevalence of diabetes in the United States. These are data from the Centers of Disease Control. It shows here the difference between the prevalence of diabetes patients identified in 1995. So we're looking here in California, it shows in the orange, dark orange, where it was 4.5%. 2 decades after that, if you look at California, it's dark red, showing the prevalence of more than 9%. So it's increasing. In addition, this next slide, please. So this graph shows the increasing or the staggering rise of the diabetes diagnosed patients in California. So it shows like it's rising. It's not even showing a plateau. It continues to rise, and this is very worrying. Now, for patients at your pharmacy, the 88 or the American Diabetes Association has this questionnaire. You can access this from the website, and patients at your pharmacy can screen themselves if they are at risk for diabetes. So it asks them about the age, if their gender, if they have like genetic predisposition, if there is a family history of diabetes, what's their weight and height, and then they add their score. If the score is equal to 5 or more, then they are at higher risk. And then they can talk to their doctor about a better plan. This is a quick refresher about the criteria for diagnosis. And here we're including the American Diabetes Association. The diagnosis for diabetes is for fasting blood glucose more or equal to 126 milligram per deciliter. Also, if postprandial glucose 2 hours after is more or equal to 200 milligram per deciliter, or their acylated hemoglobin level is more or equal to 6.5%. Any of these is considered criteria for people diagnosed as diabetes patients. Now, what are the goals? This is also a quick refresher. What are the goals for, as per the American Diabetes Association? The glycemic goal is that patients should be with acylated hemoglobin at or less than 7%. Also, the preprandial plasma glucose level should be in between 80 to 130 milligram per deciliter, and their postprandial should be less than 180 milligram per deciliter. Well, according to the American Diabetes Association guidelines, the target is, as we discussed in the previous slide, should be less than 7% in adults. They should be tested once a year. However, if their diabetes is not controlled, then it should be tested every 3 months. And also, I would like to point out to the less stringent goal here. So people with history of hyperglycemia or people with limited life expectancy, now these patients, we won't ask them to have the target of the lower than 7%. We will be looking at a lower than 8%. Why? This is based on a study, the Accord trial, where 10,000 patients were randomized into either the standard therapy of 7% or a more stringent target that's lower than 6%. So the researchers had to end the trial very early, like earlier than expected, because of the increased deaths due to hypoglycemia in the intensive group. So this is why they would look at 8.8 or more for patients with limited life expectancy or the hypoglycemia history. Now, let's talk now about the pharmacotherapy. As per the American Diabetes Association, patients should be started on monotherapy. This is the metformin and the lifestyle modification. Metformin is very popular. It has high efficacy. It's oral. It has very convenient cost, very low cost compared to other medications. There is low risk of hypoglycemia, and it's neutral on weight gain. However, if the patient is not controlled, or the patient is already starting with an acidilated hemoglobin of more than 9%, so they would be switched to the dual therapy, where metformin and lifestyle modification, in addition to any of these groups. So these classes, we're talking about sulfonylureas, cyclopentadienes, the dipeptide peptidase inhibitors, SGLT2 inhibitors, and insulin, the basal insulin. If there is no control, then patients will be switched to the triple therapy. So metformin, lifestyle modification, and 2 of these medication classes. So we want to focus now on the new recommendation that was issued in 2017 by the American Diabetes Association for patients with long-standing uncontrolled diabetes, type 2 diabetes, and those with established atherosclerotic cardiovascular disease. According to trials, this what prompted the ADA to issue this recommendation that empagliflozin, which is an SGLT2 inhibitor, or liraglutide, which is a GLP-1 agonist, are found to reduce the cardiovascular and all-cause mortality when added to the standard care. And this is a level B evidence per the guidelines. Now, let's focus on the sodium glucose cotransporter inhibitors. And the mechanism of action, usually the blood is filtered at the glomerulus in the kidney. And a major part of the glucose, 90%, is reabsorbed in the tubules. And who's responsible for that? It's the SGLT2. Now, if we block the SGLT2 by the SGLT2 inhibitors, this will prevent reabsorption from glucose and also will cause glucose to be excreted in the urine. The result is lowering the blood glucose. This is like a quick refresher. First agent to be introduced in the market was empagliflozin under the name of Invokana, empagliflozin, Jardiance, Farxiga or the dapagliflozin, the ertugliflozin or Steglatro, and there are other members, and there are also, in addition to members of this class, in combination with other antihyperglycemic agents. So, quick refresher about the SGLT2 inhibitors. They have intermediate efficacy per the guidelines, ADA guidelines. They don't cause hypoglycemia. They're very beneficial for weight loss. Their mechanism of action is decreasing the renal glucose reabsorption. However, they cause genitourinary infections, such as mycotic infections. They result in frequent urination, so volume depletion is an adverse effect. And also, they result in increased low density lipoprotein, which also will prompt us to monitor patients on SGLT2 inhibitors for the lipoproteins. So in the next coming slides, I will be talking to you about trials that have compared the efficacy of these SGLT2 inhibitors compared to others or compared to placebo in type 2 diabetes patients with comorbidities. Let's start with the empagliflozin trial, where the researchers here wanted to know the effect of empagliflozin on the cardiovascular outcome and mortality in type 2 diabetes patients. Now, patients with type 2 diabetes are usually at risk of cardiovascular disease. And patients who are with cardiovascular disease and type 2 diabetes are at higher risk of death. So if we use empagliflozin, would it protect our patient from the cardiovascular outcomes and death? So their goal was to examine the effect of empagliflozin, which is our SGLT2 inhibitor, on the morbidity and mortality in type 2 diabetes patients who are at risk of having cardiovascular events. What are the cardiovascular events? could be myocardial infarction, coronary artery disease, peripheral artery disease, or stroke. This study was a double-blind, placebo-controlled, randomized, so it's high evidence. It was carried in 590 sites in 42 countries during the period from 2010 to 2013, where 7,000 participants were randomized to receive either the placebo or the test, and a 30-day follow-up period after the treatment. So the study design, there was a major inclusion, like patients who were 18 years and older with type 2 diabetes, with a body mass index of less than 45, established cardiovascular disease, and having their escalated hemoglobin range from 7 to 9%. However, those with uncontrolled hypoglycemia, liver disease, or kidney disease were excluded from the study. So how did they design it? 400 or around 4,600 patients received the test, whether the 10 milligram or the 25 milligram empagliflozin, and the rest, the 2,000, received the placebo. So they were randomized. The primary outcome, the researchers were looking at deaths from cardiovascular cause, non-fatal myocardial infarction, or non-fatal stroke. The secondary outcome was having basically the primary outcome, which is a cardiovascular cause of death or myocardial infarction or stroke, and hospitalization due to unstable angina. So let's look at the statistical analysis. They used the intent to treat analysis where the results were analyzed based on the original group or medication the groups were assigned to. With the Cox proportional hazard model, they were looking at the time when the hazard happened or the event occurred. Here, it could be the myocardial infarction, the cardiovascular death, or any other cause. So let's look through the results. Here, those figures show the cardiovascular outcome and deaths from any cause. If we look at panel A, the one on the top left, this shows the primary outcome. So the y-axis shows the patients with events, and this is basically the cumulative incidence. What is the cumulative incidence? We're looking at newly diagnosed patients with the outcome. So the outcome here could be the cardiovascular death, myocardial infarction, or stroke, and at a particular point of time. So we're following patients here with empagliflozin. They're starting with 4,000. We're following during time, right? And then with the placebo, we're also following the starting at the baseline, and then we're following them during time. At some point, the risk or the event happens. So the figure shows empagliflozin is a red line, placebo is a gray line, and we can see that there is a significant lowering in the primary outcome with the empagliflozin group compared to the placebo. Let's look at the 10% in empagliflozin showed the primary outcome versus 12% in the placebo group. Hazard ratio was 0.86. Now let's look at the hazard ratio. We're talking about ratio. So the 95% confidence interval was in the range from 0.74 to 0.99. Because we're talking about ratio, it did not include 1, the digit 1. So that means it's statistically significant. And the p-value here was lower than less than 0.001. Let's look at panel B, deaths from the cardiovascular cause. Empagliflozin significantly lowered the deaths from cardiovascular cause compared to the placebo, and it was statistically significant as well. What about deaths from any cause in panel C? Still, empagliflozin statistically lowered deaths from any cause compared to placebo with a statistically significant result. Finally, hospitalization for heart failure, it was lower in the empagliflozin group compared to placebo as well, with statistically significant difference. We'll just go through this table quickly, so what they wanted to do here is to see subgroup analysis. So what did they mean by subgroup analysis? Was this, they wanted to know if, so we have here the primary outcome that we discussed earlier. That's from cardiovascular cause. And we want to know, what if patients younger than 65 years old, did they respond the same to like patients more than 65 years old? What about, so starting their treatment when they had the steroid hemoglobin lower than 8.5%? Was there a difference from those who had it more than 8.5%? So looking at the curve here, it's a little complicated, but we want to look at the vertical line here. This stands for figure 1. And anything that does not cross 1 is also because we're looking still at the hazard ratio. Anything that's lower than 1 is statistically significant or favors empagliflozin. So looking at all patients, we're starting with 4,000 with empagliflozin compared to the placebo. And the hazard ratio was less than 1, so it's statistically significant with the primary outcome. And also at the same time, it favors empagliflozin with deaths of cardiovascular cause. Also, if we look at the acylated hemoglobin, those starting the subgroup of less than 8.5% favored empagliflozin. And this is basically what we discussed in the previous slide, that patients with hazard ratio 0.86 were statistically significant results. So this table shows the percentage of patients hospitalized for heart failure in the placebo group and the empagliflozin group. 4.1% were hospitalized in the placebo group for heart failure compared to 2.7%. This was statistically significant with a p-value of less than 0.002. This table shows the adverse effects as discussed earlier. So we're comparing placebo to the pooled empagliflozin, like both strengths used. And there were higher events of urinary tract infections, genital infections, and also increased urination or volume depletion in the study group compared to the placebo. Finally, this is the last figure in the study. So it shows the levels of the acylated hemoglobin levels. In the y-axis, it shows the adjusted glycated hemoglobin compared to, and on the x-axis, it shows the time. And again, we're following patients at points of time. The gray triangles are those of the placebos. The purple circles are those patients who received the empagliflozin 10 milligram, and the blue circles are those who received empagliflozin 25 milligrams. As we can see, at 12 weeks, there was a significant drop in the acylated hemoglobin, and it stayed like lowered throughout the study. However, if you want to think about it, we're still at 7.5%. No one in the study reached the lower than 7% according to our goals. Remember, like the guidelines require the 7% goal. Mm-hmm. So this is considered a limitation in the study. Like they never reached the goal of the acylated hemoglobin level. So efficacy, their results, empagliflozin reduced the risk of cardiovascular deaths in patients and also lowered the risk of hospitalization for heart failure. However, genital infections and urinary sepsis were higher in the test group compared to placebo. So, in conclusion, the authors concluded that patients with type 2 diabetes and cardiovascular existing comorbidities are at lower risk for the primary outcome or cause or deaths from any cause mortality when they were started on empagliflozin compared to placebo. And the trial provides a support for the long-term use of empagliflozin for such patients. This study was published in the New England Journal of Medicine in 2015. However, as I discussed earlier, the limitation is that many patients did not reach their glycemic goal. And also the trial examined the benefit of empagliflozin only in patients who have existing cardiovascular causes, not in patients without any cardiovascular cause. They did not investigate these patients. The strengths of the study, it included a large study population. It was randomized, and it was a multi-centered study. Now let's switch and talk about a different study where SGLT2 inhibitors were used against different agents. In this study, dapagliflozin was used against exenatide. So the researchers here used data from the duration study, and they extrapolated the data to see what about the subgroup analysis. In this next slide, please. Next one. Thank you. Thank you so much. So the study, it was a 28-week multi-center study also, double-blind, where adults 18 years and old were included in the study, and they were maintained on metformin more than 1,500 milligrams daily for more than 2 months. Their estimated hemoglobin level was 8 to 12%. Treatment, they were either randomized to dapagliflozin 10 milligram once daily plus placebo, or exenatide plus placebo, or dapagliflozin plus exenatide. Now, exenatide is a GLP-1 agonist. Dapagliflozin is an SGLT2 inhibitor. The researchers were not looking at the statistical significance of adding both medications together. However, they were looking at the effect of the combination on the subgroups. Again, we're looking at patients, how would they respond to the result or to the combination or addition of both medications? In terms, would age affect the result? Would their gender, BMI, body mass index, or estimated hemoglobin level? So they were looking at the primary endpoint, which is the change of the estimated hemoglobin from baseline till week 28. And also the secondary endpoint was the change in body weight from baseline to week 28. So this curve shows the result of the glycated hemoglobin, the decrease from baseline to week 28. The figure on the left shows the effect on baseline on age groups, and this shows the kidney function. So why these? Because this is where they found differences. We're focusing now on the left curve with the age difference. The subgroup on the left is a group with younger than 65 years old, and the subgroup on the right who are older than 65 years old. If we look at the purple bar, this is where it shows the exenatide combination with dapagliflozin. And the one on the right, so there was a significant lowering in the exenatide once weekly plus the dapagliflozin compared to the other age. And also here with the estimated glomerular filtration rate, if we look at, so this is lower than 60, it's like a lowered or reduced kidney function. This is 60 to 90 milliliter, an intermediate kidney function, and this is more than 90 milliliter per minute, and this is a good functioning kidney. Patients in this group showed a better response to lowering the estimated hemoglobin compared to the other two groups. And also dapagliflozin here in the purple bar showed a better response to lowering the estimated hemoglobin compared to the two groups. And this is in agreement with the mechanism of action of the SGLT2 inhibitors, because they work on the kidney or renal reabsorption of the glucose. So The results here, the researchers wanted to know that, or to say that the present analysis shows that the combination is effective in lowering the acylated hemoglobin and body weight, irrespective of any effect of age, gender, body weight, race, or acylated hemoglobin level. And this was the first analysis combining the both classes and the treatment by subgroup. Now, the last trial we're talking about is a combination therapy. So they investigated the effect of empagliflozin and linagliptin. Linagliptin is a DPP2 inhibitor or a dipeptide peptidase inhibitor. So this linagliptin lowers the blood glucose by increasing the production of insulin, glucose-dependent insulin production. So the treatment here was using empagliflozin and linagliptin, 10 milligram or 5 milligram once daily, or 25 and 5 milligram once daily. Or they could be randomized to placebo and linagliptin instead of the empagliflozin. The study design included 52-week double-blind, multi-center trial, adults more than 20-year-old, with a body mass index lower than 40 kilogram per meter square. They were either treatment naive or were stable on other acylated, or other, for example, sulfonylurea or thiazolidine ions, with acylated hemoglobin range of 7 to 10%. The exclusion criteria, they did not include patients with fasting high blood glucose, acute coronary syndrome, kidney disease, liver disease, or if they were previously treated with a GLP-1 agonist. So the results, the primary endpoint, next slide please. The primary endpoint was looking at the change in acylated hemoglobin from baseline to week 24. And the secondary endpoint was looking at the change in acylated hemoglobin from the baseline to week 52. And this is where they started increasing the empagliflozin strength from 10 milligram to 25 milligram. So this figure shows the adjusted acylated hemoglobin on the y-axis versus the time in weeks. And as we can see, like the combination of empagliflozin and linagliptin lowered the acylated hemoglobin and even reached the target compared to the placebo and the linagliptin. In this curve, like I want to point your attention or draw your attention to that patients reach their target acylated hemoglobin of less than 7%. The proportion of patients reaching the target at week 24 with the empagliflozin linagliptin group were higher than those in the placebo and linagliptin group. At week 52 also, the proportion of patients reaching the target were higher in the combination group compared to the placebo group. This is also a graph showing the adjusted mean lowering in the fasting blood glucose compared, and on the x-axis there is a time, and we're following patients also with a combination. There was a lowering in the fasting blood glucose compared to the linagliptin placebo group. At week 24, we started up titrating the empagliflozin from 10 milligram to 25 milligram. So we go back to the safety of the study. Again, we discussed this earlier because the linagliptin and placebo group did not show as much side effects as empagliflozin linagliptin, where UTIs and increased urination were more common in the empagliflozin linagliptin group. In addition, no amputation or pancreatitis were reported in the treatment groups, which was a good result. Now let's switch gears now and focus on our medication, the empagliflozin, the SGLT2 inhibitor that's dosed once daily It's administered orally. We need to monitor, as discussed earlier, the acylated hemoglobin, renal function, any genitourinary mycotic infections. We need to monitor patients for their LDLs. If patients are started on empagliflozin, we need to monitor if they are receiving any loop diuretics because it might enhance the effect of the loop diuretics and it causes hypotension. Also, it might enhance the effect of insulin and cause hypoglycemia if they are receiving empagliflozin in addition to insulin. What are the positive about empagliflozin? It's oral, it does not cause hypoglycemia, it causes weight loss. On the other hand, it is of high cost. So this is one of the limitations on using it. And again, it's part of a commercial I included for about the Jardians, and they say it's the only type 2 diabetes treatment for patients with heart. And I would also add the GLP agonist, but this is how they advertise for the Jardians. So in summary, I would like to talk about or conclude what we talked about in our presentation. The American Diabetes Association guidelines for type 2 diabetes patients with cardiovascular disease include lifestyle modification, adding metformin, and an additional agent, GLP and SGLT2, to reduce the risk of cardiovascular mortality. The HbA1c goal is less than 7%. Patients should be aimed at a goal of lower than 130 to 80 millimeter mercury. Now, before returning to our patient, I would like to mention that there is a question and answer session after the presentation. It will be about 5 minutes of your time. Okay. So, returning to our patient, we wanted to know what is the best pharmacotherapy plan for JB based on the results of the EMPA trial and the guideline recommendations. Remember, she had hypertension, dyslipidemia, history of myocardial infarction, acylated hemoglobin was 8.9, and she was obese. So I would say these are, or this patient is matching the population in the EMPA study to a good extent. She was using metformin 500 milligram twice daily. She was using glipizide 10 milligram twice daily. She was also using atorvastatin, amlodipine, and aspirin. What would be a good next step? So ensuring medication adherence and lifestyle modification is important. I would recommend discontinuing sulfonylurea and adding empagliflozin to her metformin therapy. We want to switch the patient to a high-intensity statin. Now she's on a moderate-intensity statin. Increasing her atorvastatin to 40 milligram would switch her to the high-intensity statin. We want to switch her to ACE inhibitors such as lisinopril to protect her kidneys and discontinue the amlodipine. Would she be a good candidate for the SGLT2 inhibitor? According to the guideline recommendations and the results from the EMPA study, she has type 2 diabetes, she has history of myocardial infarction, she also is receiving other antihyperglycemic agents, so she would benefit from adding empagliflozin to her regimen to protect her from atherosclerotic cardiovascular events. This is my reference slide. Thank you. And I would like to ask if there is a...
Okay, yeah, we have questions. So let's start with Mohammed.
Hi, Noha. I didn't recognize you actually.
So we're waiting on the questions session.
And that?
Okay.
Okay.
Okay. So
In the
if there's any
INCA
question.
trial, did the placebo group receive any anti-hyperglycemic medications in addition to the placebo?
Answer me. Okay, so patients were actually receiving. So I do apologize because Mohammed had to leave for work. So patients received actually, they were started on sulfonylureas and also other medications such as metformin, and they were continued on their medications up until during the trial. So the placebo group did not stop any anti-hyperglycemic medication. They were continued on their metformin and the sulfonylureas.
Okay, so my question is, in the IMPA gliflozin trial, what is the benefit of the IMPA gliflozin on the heart?
Okay, thank you so much for asking this question. So actually, I was interested in this criteria. So the empagliflozin, the researchers just reported that the empagliflozin had a benefit on the arterial stiffness, the cardiac function, and the cardiorenal function. So this was also in addition to the lowering on the blood pressure and without increasing the heart rate.
Oh, thank you so much. It was a very interesting, really facts, and I love it a lot.
Thank you. Yeah. Thank you so much for asking and for being here. And I do apologize if Mohammed had to leave.
Yeah, he just left
for work. So we do thank you for your time and your attention today. Thank you.
You want to see my cat? Yeah.
Just a second. Just a second. Just a second. What's cute,